Hi all, welcome to Physio Exam Buddy. This video is on the peptic ulcer as well as the gastric mucosal barrier, an important repeatedly asked exam topic. Let's revise the core concepts in just a few minutes. First of all, we can see a clinical scenario. That is, a middle-aged man complains of epigastric pain, and the pain occurs when he is in empty stomach, and the pain will subside after taking the food or after taking antacids. And he also complains of occasional vomiting. So what's your provisional diagnosis? And list the causes as well as treatment. The answers for these questions we will get from this video. So what's your provisional diagnosis? If it is epigastric pain subsiding or related with food as well as antacids, the most probable diagnosis it is peptic ulcer. So what is this peptic ulcer means? It is an excoriated area of the gastric or duodenal mucosa. And the most common sites where we will get the peptic ulcer is in the first few centimeters of the duodenum, and that is a common site for the duodenal ulcer, whereas the gastric ulcer, it is mainly seen in the lesser curvature of the antral end of the stomach. And out of these peptic ulcer, the duodenal ulcer is more common than the gastric ulcer. Next, we will see the second question, that is, list the causes. So, what are the causes for peptic ulcer? Mainly multifactorial, and it is mainly this peptic ulcer, it is mainly due to the imbalance between the rate of secretion of the gastric juice and the degree of protection by the gastroduodenal mucosal barrier. So, the main culprit for this peptic ulcer is the disruption of the mucosal barrier. The most important thing you have to explain when the cause is asked for peptic ulcer is the gastric mucosal barrier. Our stomach wall is protected from the acid as well as peptic activity by this gastric mucosal barrier. And the main components of the gastric mucosal barrier include, the main one is the mucus, which is secreted by the neck cells of the gastric glands as well as from the surface mucosal cells, and they are mainly made up of glycoproteins, particularly mucins, and they form a flexible gel coating of the mucosa. And the second component, it is the bicarbonate secretion from the surface mucus cells lining the stomach. And this bicarbonates will get trapped in the mucus gel. And a pH gradient is established in the stomach such that the pH at the luminal side of the stomach lumen, it is maintained at 1 to 2 at the luminal side, whereas the pH at the surface epithelial cells, it will be maintained at a range of 6 to 7. So, the HCl, which is secreted by these parietal cells, will cross this barrier through a finger-like channels, leaving the rest of the gel layer intact. And other components of the gastric mucosal barrier include certain intercellular tight junctions, which provide a barrier for the back diffusion of the H+. Then the high mucosal blood flow, which will carry away the acid from damaging the underlying mucosa. Then prostaglandins will help to maintain the mucosal barrier, and there are new thing which is known as trefoil peptides, which are actually clover leaf-like structures seen in the rapidly proliferating tissues, and this makes the acid resistance to the mucosa. And the damaged cells are quickly replaced as turnover rate of this gastric mucosa is very high. So these are one of the most important factors which protect the gastric mucosa from ulceration. Now we will see what are the causes for the breakdown of this gastric mucosal barrier. The main culprit is the infection by a bacteria which is known as Helicobacter pylori. It will burrow through this barrier by releasing certain bacterial digesting enzyme which will liquefy this barrier. And certain drugs also causes breakdown of this gastric mucosal barrier, which include mainly the painkillers like aspirin as well as other NSAIDs. And the mechanism of action by which these painkillers act is by inhibiting the production of the prostaglandins, thereby decreasing the mucus production as well as bicarbonate production, and it also will decrease the cell renewal rate in the gastric mucosal barrier. Prolonged excessive secretion of the acid is another culprit for this peptic ulcer, mainly because of gastrinomas, that is gastrin secreting tumors, especially having in case of Solinger-Ellison syndrome. Then smoking, alcohol, hereditary factors, genetic predisposition as well as emotional factors are also the causes for peptic ulcer. Next is about clinical features of the peptic ulcer. They are more common in males and especially the duodenal ulcer. It will present like burning pain in the epigastrium, usually 2 to 3 hours after food intake and relieved by food or antacid. And if the pain usually occurs just after the meals and relieved by vomiting, it is mainly because of this gastric ulcer, and this gastric ulcer usually presents with weight loss. Next, about the complications of the peptic ulcer, which include hemorrhage, perforation as well as obstruction due to scarring in the ulcerated area. And the diagnosis, basically the diagnosis will happen by taking a good clinical history, and the diagnosis can be confirmed with endoscopy as well as biopsy, which will again confirm the H. pylori infections, and a previously barium meal can also confirm the diagnosis of peptic ulcer in the previous years. But recently we are now using the endoscopy as well as the biopsy. Next, about the answer for the last question, list on the management of the peptic ulcer. So the management is mainly aimed by inhibiting the acid secretion as well as by enhancing the mucosal resistance. That is enhancing the resistance of this gastric mucosal barrier to the acid. So the medical treatment first. First, we can use drugs which decreases or neutralize the acid secretion. And the drugs that decreases or neutralize the acid secretion include antacids. You should at least remember 2 or 3 names, that is aluminum hydroxide, magnesium hydroxide and calcium carbonate. They are the main antacids used in the treatment of peptic ulcer. Then H2 receptor blockers like cimetidine or ranitidine can also be used. Then muscarinic receptor blockers like atropine can also be used for the treatment of peptic ulcer. And H plus K plus ATPase blockers like omeprazole as well as pantoprazole can also be used in the medical treatment of the peptic ulcer. And the drugs which enhances the resistance of this gastric mucosal barrier include sucralfate as well as colloidal bismuth subcitrate. Certain prostaglandin E agonists can also be given. The example for this PGE agonist include misoprostol. And the H. pylori infection, if the gastric mucosal barrier is disrupted due to the H. pylori infection, you have to use antibiotics for treating the H. pylori infection. And if the medical treatment fails, then you have to go for the surgical treatment like vagotomy, but not usually done. And in case of gastrinomas in Solinger-Ellison syndrome, and surgical treatment has to be given. And a few words about the drug therapy to eradicate the H. pylori infection. Basically, it is known as the triple drug therapy, and it includes giving bismuth compound 2 tablets 4 times daily, then metronidazole 500 milligram again 4 times daily, along with any other antibiotic like amoxicillin or tetracycline. And this triple therapy, it is usually given for 2 weeks along with our H2 receptor antagonist or proton pump inhibitor, which will eradicate the H. pylori infection to almost 98%. So that is about the peptic ulcer. Thank you.